Assalamu alaikum doctor. In this video I am discussing a recall communication, that is talk with the medical student about neonatal fluids calculations. So as usual we are starting with IRCAP. Then why the medical student asking that why the difference between the formula for IV fluid in neonate versus the pediatric. So what is the answer we give? Why there is different? First of all, number one, kidneys are immature, lose more water in neonate. Then number two, large surface area in comparison to weight, so more water loss occur and more fluid in their body, especially extracellular portions. And that's why a neonate need more fluid, especially preterm infant needs more, and all that because different physiology. Some medical condition more fluid like under heater and high rate of growth in neonate and child. So what are the cause? Neonate need more fluid. First of all, neonate have immature kidney, that's why there is water loss occur. Number one, comparing to weight, their body surface is more, that's why water needed. Number three, their growth is much more than the pediatric child, that's why needed. Some condition like heater, the child newborn, so need more fluid. And preterm also need much more fluid because of their different physiology. And also we tell that more fluid in their body, especially in the extracellular portion, so that's why we need the neonate more fluid. Then how can we know that if hydrated or overhydrated? How can we know? So for by weight, by we monitoring the child is hydrated, electrolytes, some lab test, electrolytes, urea, creatinine, urine osmolarity. So lab electrolytes, urea, creatinine, urine osmolarity. And clinically we examining the weight, urine output, then entry fontanelle, auscultate the chest for basal crepitations, then skin turgor and heart rate. So clinically weight, urine output, auscultate the chest, then skin turgor, heart rate, anterior fontanelle. By that we understand. And we should be aware of phototherapy, increase IV fluid, but there are new modulations now without loss. So phototherapy we give the IV fluid much more, but there is a new modulations now without loss. In respiratory distress we decrease the IV fluid or heart failure. So in respiratory distress IV fluid decrease and heart failure decrease. So why need total parenteral nutrition, TPN? Long term IV fluid on can take oral. So when there long term IV fluid then can't take oral, then we give the total parenteral nutrition, TPN. There is fluid plus carbohydrate plus protein plus lipid, fluid plus carbohydrate plus protein plus lipid. But take care monitoring the liver function test and vitals for sepsis, lipid profile, hyperlipidemia, and ultrasound of the abdomen, TPN, cholestasis. So total parenteral nutrition, because of when they take long time IV fluid, they are not taking oral, that's why we give TPN. TPN contain fluid plus carbohydrate, protein and lipid. But we should need to monitor something. If sepsis, we liver function test and vitals. Hyperlipidemia, we do the lipid profile, and TPN, cholestasis, that's why ultrasound of the abdomen. So what is TPN indications? When we give the TPN, they are asking. Indication of TPN are decrease the 30-week gestation or decrease less than or equal 1000 gram to start ASAP. So if the less than 30 week of gestations or weight is less than or equal 1000 gram, then recovering conservative treatment for NEC. During necrotizing enterocolitis, recovering conservative treatment. If undergo surgery for gut anomalies or acquired gut, if not taking feeding for more than 5 days. So less than 30 weeks of gestation, weight is less than or equal 1000 gram, recovery conservative treatment from NEC, more than 5 days, not taking any oral fluid. Okay, undergo any surgery for gut anomalies and gut, so any undergo any surgery. Monitoring daily fluid. What we monitoring when TPN? We give daily fluid input and output, urea and electrolyte first 7 days, then after consultations blood glucose if more than 11 millimole per liter and urine glucose. Weekly we do the length, height, circumference, liver function test, calcium, magnesium and phosphate. Okay, and 4 weekly what we do? 4 weekly we do the serum triglyceride, fat soluble vitamins, zinc, copper, magnesium, vitamin B12, folate, ferritin and selenium. Again I am telling TPN indication already tell the monitoring daily, weekly and 4 weekly. Daily we are urine output, okay, fluid input output, urea and electrolyte first 7 days, then after consultations blood glucose level. These three are we are doing input output fluid, random blood sugar and the urea and electrolyte. We are doing length, head, circumference, liver function test, calcium, magnesium and phosphate level. Now we are going for weekly. What we do is serum triglyceride, fat soluble vitamins, zinc, copper, magnesium, vitamin B12, folate, ferritin, and selenium. What is the complication? Complication is the line infections, septicemia or extravasations, electrolyte disturbance, and acid base intolerance. Metabolic or hyperlipidemia, hypercholesterolemia, conjugated hyperbilirubidemia, and cholestasis. These are the complications occur, like electrolyte imbalance can occur, hypercholesterolemia, hyperlipidemia, cholestasis, acid base balance disturbance, then infections, septicemia. Okay, these are the complications. That's why we are following for total parental nutrition. Then the medical student asks, what is insensible water loss? Water and fluid loss from the body, we can't estimate it through skin, sweat, or lungs, exhaled air. Okay. So that is we cannot count, like via skin, via taking the respirations during sweating. These are sensible water fluid loss, or loss of fluid we can estimate, like urine or suction, sodium aspirate. These are B, weighing and adjusting IV fluid. So sensible water loss we can count, like urine output, like suctions, like aspirations. So that time we wait and we adjust the IV fluid. Then they ask that we have some precaution while IV cannulations. Precautions are gestational age, vital size, input and output, type of fluid. In some condition, decreased fluid requirement, respiratory statement, heart rate, PDA, then meningitis, hypoxic ischemic encephalopathy. Increased fluid intake are phototherapy, vomiting and dehydrations, and hyperthermia. So we tell that fluid requirement decrease in respiratory distress condition, heart failure, any cardiac conditions, meningitis, hypoxic ischemic encephalopathy, increase when increase phototherapy, vomiting, dehydration, and hyperthermia. And precaution while IV calculations are according to gestational age, vital signs, input and output, and type of fluid. So how can I compensate the maintenance fluid to balance fluid canal? IV required in day and then according to condition plus sensible fluid loss. Answer is, how can I compensate the maintenance fluids to balance fluid content? IV required in day according to condition and plus sensible fluid loss. So according to how much fluid he need plus sensible fluid loss, we can maintain by that. So this is all about neonatal fluid management, medical student communication. Thank you.